Learning with other GPs at in-person or virtual events gives you a bit of a buzz, and alongside e-learning, it's an important part of learning for appraisal. MIMS Learning offers plenty of opportunities for live learning, and you can find details on our events page at mimslearning.co.uk/events. Have a look today. Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to be joined today by my colleague Dawn Liz Powell. We previously did a podcast episode on ear problems, including tinnitus, which was a booming success with our listeners. One of our most downloaded episodes, I think.
Hear, hear, which unfortunately is not the worst pun you will hear this episode. Anyway, ears of course fall under the ENT speciality of ears, nose and throat. So today let's have a look at the next area, the nose. We have lots of good learning around presentations of nose problems that GPs, brace yourselves, might sniff out. So let's put our noses to the ground and have a good look around. Sorry, I did say there would be some really stinking puns in this episode.
So first up, we have a useful module on red flags associated with nasal problems written by GP Dr. Anish Kotecha. He says that nasal symptoms are a relatively common presentation and are mostly benign, but it's important not to miss an underlying sinister cause. His module mentions key types of nasal problems, and in this list I noticed loss of sense of smell, which is a concept familiar to me. After a bout of COVID in 2020, I had a complete loss of sense of smell for about 9 or 10 months, which was kind of odd.
You know what, my sense of smell has never been great, but it must be really odd not to have it at all. Obviously, though, loss of smell is a very well-known sign of COVID.
Yeah, and I think I got off lightly given some of the other long COVID symptoms that you can have. Dr. Kotecha says a reduced sense of smell can be a red flag, although I guess that has to be set in context where an obvious cause such as COVID is concerned.
Though disturbances of sense of smell are also mentioned in our module on the NICE guidelines on neurological conditions. In this module, Dr. Sonia J reminds GPs that a history of a loss of smell that is not connected to a rhinological cause or a known neurological cause such as Parkinson's should be referred to a neurologist. She says to be particularly vigilant in young people and those with other associated focal neurological deficits such as headache, memory issues or personality change, as this could suggest malignancy. Transient or repetitive smell hallucinations could require referral to exclude temporal lobe epilepsy as the cause, and apparently loss of smell after head trauma is also quite common.
Oh, that's interesting. I didn't know that about head trauma. If you have trauma to the nose itself, that can cause a lot of pain, obviously, and could even involve a fracture. And a GP called Rakesh Chopra, Dr. Chopra, gave a fascinating talk about ENT emergencies at one of our MIMS Learning Live events, and we did a conference report about this. And he talked about nasal fracture, and he said patients with a suspected nasal fracture should be seen by an ENT specialist within 2 weeks. When a patient attends with a nasal injury, the GP should look at the nose from the inferior aspect, which I assume means looking up the nose, and if they see a bulge on either side of the nasal septum, this could suggest a septal hematoma, which is a surgical emergency. And even more worryingly, if they see a unilateral clear drip from the nose after injury, that could be a loss of cerebrospinal fluid.
Hopefully, most presentations of nose problems do not have quite such dramatic cause. However, another thing Dr. Chopra mentioned that could cause a bit of drama is the presentation of a foreign body in the nose. Dr. Chopra said that the presence of a battery in the nose is an emergency. Really? Who would have thought? And warrants immediate referral. Other foreign bodies in the nose carry a risk of aspiration and should always be suspected in a child with unilateral nasal discharge. Dr. Chopra reminds GPs it's not a good idea to try to grasp foreign bodies that are round, as they might go further in, and not to irrigate organic items such as peas, as they might absorb water and swell.
That's great advice, and I will try to remember not to put peas up my nose, and if I do, not to add water afterwards.
Do you know what? That reminds me of an episode of Friends. So the group are babysitting and they're priding themselves on keeping the kids safe, until that is Chandler, who is an adult, by the way, has to go to hospital because he starts choking on a toy. The joke being that everybody was watching the kids, but nobody was watching Chandler.
So we've looked at loss or alteration of smell and some emergencies. Epistaxis or nosebleed could be another potential emergency, and recurrent nosebleeds have a wide range of differentials. These are a symptom that can be harmless. I remember lots of minor nosebleeds as a child, or they can cause major problems. Dr. Chopra reminded GPs that Trotter's manoeuvre should be used to stop nasal bleeding. This involves sitting and leaning forward slightly while gripping the cartilage of the nose and not the bony dorsum. Of course, bleeding not stopped by direct pressure with or without the presence of hemorrhagic shock is an emergency. We also have a module on epistaxis by GP Dr. Sunita Kachar, in which she provides tips on red flags to look out for. She lists recurrent unilateral epistaxis, nasal obstruction, rhinorrhea, facial pain, facial numbness or diplopia. The patient being on anticoagulant therapy or signs suggestive of a bleeding disorder are also red flags. Dr. Kachar also talks about possible causes of nosebleeds, as well as trauma such as injury to the nose. Dawn, can you speculate on other possible causes?
Thinking allergic reaction or maybe even malignancy.
Yep, definitely right on both counts. So allergic rhinosinusitis, that is hay fever, or nasal polyps may cause nosebleeds. And Dr. Kachar says that rarely local damage to blood vessels may be caused by squamous cell carcinoma.
I think you just mentioned anticoagulants. Can other drugs be a cause of nosebleeds?
Yes, they can. So as we alluded to a minute ago, anticoagulants might be an obvious cause to look for as they prevent blood clotting. However, topical decongestants can also cause nosebleeds, along with antiplatelets and, of course, illegal drugs such as cocaine. So drugs are worth looking into. Dr. Kachar also points to haematological causes, including coagulopathies, acquired coagulopathies caused by liver or renal disease, thrombocytopenia, or platelet dysfunction in von Willebrand disease.
There really are lots of possible causes of nosebleeds.
Yes, there are, and I'm learning a lot about this as we go. Dr. Chopra's talk had even more detail about when to consider referral for a patient with recurrent epistaxis. And if you go to the module itself, you can find full details, which are well worth a look. But here are a few highlights. So in males aged 12 to 20 years, angiofibroma is a possible but rare cause of nosebleeds. And people of Chinese origin have a higher risk of developing nasopharyngeal cancer, so GPs should bear this possibility in mind if they have recurrent epistaxis. And of course, nasal, sinus and nasopharyngeal cancers are more common in people aged 50 and over, and again that should contribute to GPs thinking around recurrent nosebleeds. Dawn, can you guess another cause of recurrent nosebleeds mentioned by Dr. Chopra?
Yes, actually, I'm thinking about my late dad. He suffered with horrific nosebleeds throughout his life and was eventually diagnosed with hereditary hemorrhagic telangiectasial HHT. I hope I haven't inherited that, but I did get his bloody mindedness.
Well, some things get passed on. And Dr. Chopra actually mentioned this. He mentioned people with a family history of HHT. And I've looked up the incidence of this, and it apparently affects 1 in 10,000 people, which is not that rare. This disorder means blood vessels can develop abnormally. And Dr. Chopra says that if your patient with recurrent nosebleeds also has suggestive features on examination, such as telangiectasia on the lips, mucous membranes or fingers, then you should refer.
Okay, so that's nature. What about nurture? Is there any environmental causes?
Yes, there are. Apparently, occupational exposure to wood dust or chemicals can cause epistaxis. So if your patient's a carpenter, for example, you could factor that in.
Funny you should mention wood dust, because spoiler for next week's episode, Bev Bostock, who's going to be talking to me about long-term respiratory conditions, mentions that wood dust can lead to an exacerbation of asthma in people with asthma as a child. Anyway, so you mentioned hay fever being a cause of nosebleeds, and like nosebleeds, hay fever is a very common condition seen in primary care. Should we talk about that now?
Yes. I mean, it is very common and it's very uncomfortable. I have a family member affected by it and it does look really miserable.
Yeah, so I mean, hay fever afflicts, and afflicts being very much the operative word, a quarter of the population. It stems from a misplaced immunological response more suited to removing parasitic worms. The classic symptoms of sneezing and nasal itching, running, and blocking occurring at a particular time of year usually suggest hay fever, particularly if combined with eye watering, redness, and itching. Avoiding allergens such as pollen and mould can be very difficult, so there is a range of treatments that GPs can try. Professor Gladys Scadding's clinical review on the topic provides information about all of these treatments, including intranasal corticosteroids, which are more effective than antihistamines and leukotrienes. Oral antihistamines are less effective than intranasal corticosteroids and slower in onset than intranasal antihistamines. Combined sprays, which contain corticosteroids and nasal antihistamine, are now available. Intranasal decongestants relieve obstruction temporarily, but should not be used for more than a few days at a time. Can I just say, I was just looking at this module the other day, and the advice on how to use nasal spray was an absolute game changer for me.
Oh, that's good. What made a difference to you?
Well, it sounds obvious, but bending down and spraying means it actually goes in and has an effect. So, listeners, if you are prescribing nasal sprays, do make sure your patients know how to use them.
Great tip. And what about immunotherapy? Is that effective for hay fever?
Well, if you have hay fever and are given an allergen-specific immunotherapy by injection or under the tongue, it can alter the course of the disease. Professor Scadding says that patients whose hay fever is uncontrolled, in spite of taking optimal pharmacotherapy, would be candidates for referral for immunotherapy, along with those who cannot tolerate pharmacotherapy. Also, small children with early problematic hay fever should be considered for sublingual, so under the tongue, immunotherapy, as early use of this therapy could lower the risk of progression to asthma.
That's really interesting. We talked about hay fever, but that's just one cause of a blocked, discharging or uncomfortable nose. There must be lots of others.
Yeah, so GPs should have lots of other things on their radar as possible causes of these symptoms. These could include viral infections. An obvious example of that is the common cold, nasal polyps, adenoiditis, and turbinate hypertrophy. As mentioned, it's also worth considering malignancy in the form of nasal or paranasal sinus cancers.
If we go back to the first red flags module that we mentioned, which was the one by Dr. Kotecha, he listed a whole bunch of red flags, including things like facial swelling, nasal lump, weight loss and lymphadenopathy, which could all be linked to malignancy, although I guess they could have other causes. And yet another red flag module, we have one on facial pain. And in this one, there's a reminder to GPs that a nasopharyngeal carcinoma can cause unilateral hearing loss as well as nasal obstruction. And also in the eye, tearing due to obstruction of the nasolacrimal duct. And just finally, carcinoma of the maxillary antrum can also present with unilateral epistaxis and nasal obstruction.
Dr. Kotecha also says that a thorough examination of the ear, nose and throat is vital, including visualization of the nasal septum and mucosa, as well as the turbinates. Blood tests might include a full blood count and C-reactive protein, as well as a clotting screen. He also says pay particular attention to persistent and unilateral symptoms, or those that have been refractory despite multiple attempts at treatment.
Yes, and I suppose that given that if 1 in 4 people has hay fever, you might have to look beyond the hay fever sometimes to see if there's another underlying cause of symptoms. So it's been really interesting to have a look up the nose, and thanks for discussing this topic with me, Dawn.
I can't believe you've just said that.
I did. I said it, and I'm going to stand by it. There's clearly a great deal going on in there, and there are lots of conditions to keep an eye out for. So what have we learned today? So, first of all, if you encounter recurrent unilateral nasal symptoms such as recurrent epistaxis or obstruction, have a more detailed look into the problem. The presence of other symptoms, including pain, numbness, eye involvement, facial swelling, nasal lump, weight loss, or lymphadenopathy, should get your alarm bells ringing. Second, the causes of recurrent epistaxis include malignancy, particularly in older people or those of Chinese heritage, along with adenofibroma in adolescent males. Third, immunotherapy for hay fever is recommended for those whose hay fever is uncontrolled, in spite of taking optimal pharmacotherapy, and for small children with early problematic hay fever, as early use of this therapy could lower the risk of progression to asthma. As already mentioned, next week Dawn will be speaking to Beverly Bostock, who's an advanced nurse practitioner, about long-term respiratory conditions. I'm really looking forward to that and hope you can tune in too. Don't forget you can claim CPD credits for listening to these podcasts, and there are many more available. To get your certificate, along with links to the resources that we've mentioned, just go to our website at mimslearning.co.uk. You've been listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. See you next week.